I do have some talking points throughout the presentation, so if you have questions during it, please feel free to ask. Okay? Get this started. So selected topics in pharmacoeconomics, managed care, and healthcare. So I do have some learning objectives for you. I want you to understand the definitions of pharmacoeconomics, managed care, and healthcare. They're fairly self-explanatory, but I'm going to give you some definitions that medical professionals use. Compare how much the U.S. spends on healthcare to other countries. Laugh at some memes about college life and throw in some memes. Come on. Understand where the money is going in healthcare. Understand why drugs are so expensive. And compare branded and generic drug prices and which commonly cost more. Understand some possible solutions to decreasing the prices of drugs. And understand some factors that impact supply and demand within pharmacy and what effect something may have on a supply and demand curve. So definitions, pharmacoeconomics. Description and analysis of the cost of drug therapy to healthcare systems and society. Managed care, an approach to the delivery of healthcare services that puts limited resources to best use in optimizing the care of patients. And healthcare is the maintenance or improvement of health via the prevention, diagnosis, and treatment of disease, illness, injury, and other physical and mental impairments in human beings. So I do have a brief history up here. So the first insurance, 1850, the Franklin Health Insurance, really the only thing it protected you against was fires. So it's not the healthcare insurance we think of today. Prior to the 1880s, innovations focused on improvements to quality control, improvisation, sanitation, and technological advances. By quality, we're talking sewage system, toilets, sinks, the things that we take for granted today. That was very innovative then. From 1883 to 1948, we had the development of 4 models of healthcare, which we'll talk about next. These are just the basis of what other countries follow. Our country follows this as well, to an extent. In the 1920s, the development of hospital insurance plans. So these are your HMO plans. So what hospitals actually did was, in the 1920s, there was a major issue with funding and getting patients to come to hospitals. So what they did was they banded together with local healthcare providers to funnel them through this system. So that is what they mean when they talk about HMO. Those plans still exist today. They are not as common. More commonly, you'll hear PPO, and there's actually another called a PSO that's even more recent, which is just a combination between the two. 1935, Social Security signed into law. So you think of Social Security, mainly covered retirement benefits, welfare. These aren't the true Medicare and Medicaid that we think of. From 1939 to 1945, World War II, companies were prevented from raising wages to wage control set by federal government, but employee benefits weren't regulated, so employers increased benefits to encourage potential employees. This is actually a major issue now with small businesses. So businesses now, a lot of them, the larger ones, are still required to provide insurance to employees because of Obamacare and just federal mandates. The issue is they are incurring more of the cost than individuals. Now, during World War II, that wasn't really an issue, but our population has grown so much now that the current system can't really maintain it. In 1945, public health insurance bill failed due to fierce opposition from public fear due to socialism. So this was a unique period, the fear of communism, the fear of socialism, that I'm sure you've discussed before or will discuss in your history courses. But anything innovative during this time period with regards to healthcare, they slapped that socialism term on it, and it was almost instantly shut down. Whether it was good or bad, it was just socialist, it was bad. 1965, expansion of Social Security in the form of Medicare and Medicaid. That's the more standard Medicare and Medicaid that we think of now. Now it has undergone many renovations since then, which maybe we'll talk about. We'll see if we have time. 1980, development of preferred provider organization plans. Those are the PPOs I talked about. So essentially in a PPO plan, you can go to any doctor you want, any specialist, any healthcare provider, and see them. You do not have to be funneled through like an HMO plan, okay? 1970 to 2010, the desire and eventual development of universal coverage in the form of Obamacare. So why should you care? Each country has a unique approach to healthcare. The development of private insurance was largely due to circumstance, and there still exists a great debate of whether it is more harmful or beneficial in modern society of the US. We are still the only developed country that lacks a universal healthcare system. Obamacare is not a universal healthcare system. Can anyone tell me why? Or why do you think it's not a universal healthcare system?
So you have choice of your insurance, right?
It's not because of choice.
It's not mandated.
Not because it's not mandated.
But you still have to pay for it, right?
You do still have to pay for it. The bottom line with Obamacare, it does not cover everyone. There's still 10% of the population. So you'll hear a lot of politicians talk about universal health care, Obamacare. The thing is, when we compare ourselves to other countries, it's not even close. We still have 10% of our population that's covered by nothing, no insurance, anything. So Obamacare by itself is just an expansion to the existing Medicare and Medicaid essentially. Okay? I like the answers though. Okay. I mean, if you don't study, you shall not pass. It's very true for high school, but also true for college. So I'll talk about 4 models of healthcare: the Bismarck Beveridge National Health Insurance Model and the out-of-pocket model. So the Bismarck model. It's the model that most countries base their healthcare system on. Countries that use this include Japan, France, Belgium, Switzerland, and some of Latin America. Rulers or heads of government invest in people's healthcare to make a country economically capable. And there's a quote that they commonly say for the Bismarck model: a healthy population is a productive population, and a productive population makes for a strong economy, and a strong economy makes for a strong country. The Beveridge model. Healthcare is paid for and provided by the government through tax payment collected from people and companies. Healthcare is treated as a public service, similar to the police department, the fire department. Countries that use this model include Britain, Italy, Spain, Hong Kong. Hospitals are owned by the governments, and medical doctors are treated as government employees. Due to the above, the government controls expenses by limiting what can be charged for services. This is becoming more popular. We'll see how it holds though. The National Health Insurance Model. Providers are private, but payers are essentially a government-run insurance program that every citizen pays into. Insurance plans collect premiums from everyone and pays all medical bills. Countries that use this include Canada, Taiwan, and South Korea. And then the out-of-pocket model, the harshest of the models. The rich and powerful get care, and the poor stay sick or die. Countries that follow this: Cambodia, India, Egypt. So what about the US? What are we? For workers under age 65, we're largely considered a Bismarck model, where employers and employees share the cost of premiums, insurer then picks up the rest of that cost, and employees pay a copay or co-insurance. For veterans, active military, Native Americans, we are a Beveridge model with essentially no charges for services. For those over 65, national health insurance, but providers are not limited to how much they can charge. For uninsured or underinsured, we're out of pocket. So I just threw this in there, just how other countries do things. This is just another way to view what I already explained to you with the different models. Now, I just want to point out that remit in this case just means who pays in to these insurance plans, okay? Doesn't mean studying a few minutes every day, study for 30 hours straight one day before the exam. There are people that try to do this. I don't recommend it. You will not get a good grade. I have done it. I actually did it for economics, sadly, and managed to get the A, but I don't recommend that. It's not for everyone. There's actually some false questions. So in terms of healthcare, the U.S. is the most efficient in allocating funds. How many of you think that's true or false? False? Okay. Correct. The U.S. spends more on healthcare than any other developed country. True or false? Okay. True. The US has the highest life expectancy compared to other countries. Yeah, that's a sad one, but false. Expenditures versus GDP. So the PPP in here, Mr. Nelson, what was the correction I told you earlier?
PPP, purchasing power parity.
There we go. I incorrectly assume price per person. That's just a common thing that I see in literature. But when we're talking about economics, they're talking about the purchasing power parity to compare countries. So per capita, just another way of saying per person. US health expenditures per capita is expected to be greater. Do you guys think it should be? Do you think we allocate enough funds, more than enough? We'll see. Switzerland is a country comparable to the US in terms of healthcare, yet we spend 31% more than they do. And this is just another way to look at that other graphic that I showed you. So you can see visually now, we're spending 31% more than Switzerland, and we're about 2 times the average of comparable countries. Has it always been this way? The US has outspent all other developed countries since 1970.
Could you go back real quick?
Yeah.
So is that showing, on average, each person in the U.S. is spending $30,000 a year? Or is it just saying the total healthcare spent
It's
is?
10,000.
I thought
I
it
know
said,
it's hard to read.
on the previous graph it showed, doesn't it say 30 up there?
Yeah,
Oh,
it's 10.
I do need my eyes checked. But either way, so it's saying that each person spends an average of 10,000. That has nothing to do with the government, that's us.
Yes, that's
Okay.
just us. And we'll talk about why that is in later slides. So long as I can get through most of them. We'll see. Okay, so has it always been this way? Yeah, we've outspent all countries since 1970. The most recent data suggests that as a function of GDP, total health expenditures are around 18%. Some studies say 17.9%. It's going to increase if we don't change anything. How much will they continue to rise? It's not well known. So from 2010 to 2016, we increased at a rate of 4.6%, which is better compared to previous years. We increased at 7.2%. But we're still increasing is the point. So there are no assigned seats in college. However, people will sit in a seat that you normally sit in. You will just sit there and be like, come on, my seat. So public versus private sectors. So the private sector, insurance provided by private entities. Example of this, Blue Cross Blue Shield, Sigma, Highmark. The public sector, insurance is provided by public entities such as the government, and examples include Medicare and Medicaid. Does anyone know who Medicaid and Medicaid, or Medicare or Medicaid serve? Low income and elderly, those over 65 for Medicare, and Medicaid, low income, children. Which sector do you guys think is better? I know, kind of a loaded question. That's okay. Public versus private sector spending. So notice how the US public and private sector expend about the same, but other countries don't. Now, a big reason for this, like especially in terms of Canada. So Canada actually has a true universal healthcare system that everyone's covered. The problem with Canada is they still have a private insurance market. The thing about it is, when you have very wealthy individuals contributing millions of dollars in taxes to the Canadian government, they expect service that's equivalent to that. But everyone in Canada is served the exact same way. So the only way they benefit is through private insurance. So that's one of the few loopholes of Canada. And it's arguable whether that's good or bad. But it's similar to the US, and it's essentially you get what you pay for service. So total health expenditures when the US is divided into public and private sectors. So we see on the graph there, there's a large argument on whether private and public, it's good or bad. It's essentially the same. there's not one answer to sway into the other. The benefit about public is we can actually see where the funds are going. Now, regardless of your ideology, they are an example of inefficient resources, especially when we compare them to other countries. So why are healthcare costs increasing? Oh, sorry.
That's okay, I was just gonna ask, so my brother works at like a Medicare dental clinic, so I don't think it's a Medicare dental clinic, but like 95% of their patients are Medicare. So he's not like a government employee, is he? Like Medicare is the insurance for people that are coming in.
Yes, so Medicare is essentially only insurance. There are doctors, dentists who have private practices who accept Medicaid and Medicare, but that's the same as private insurance. So you go to your doctor and show them your insurance card. That's essentially the same thing your brother is doing. He's just accepting Medicare cards.
Okay, and then like the public sector for healthcare, that would be can you explain the difference?
So private essentially is probably what most of your parents have, the insurance most of you should be covered by. They should have private sector insurance. So some of you in here may have the Blue Cross Blue Shield. That's what I'm under. As far as public, that is specifically Medicare and Medicaid. The other plan that they like to talk about in Indiana is the HIP 2.0. You may have heard of that. Some people may even be on it. I'm not asking you to tell me if you're on it. There's an argument whether that's Medicare and Medicaid. We won't get into that. Do you kind of understand? It's where the funds come from to pay for things.
Okay, so there isn't like a public hospital that's run by the government that's providing service. Would that be universal health care, or would universal health care just be like insurance for everyone?
Universal health care would be insurance for everyone, essentially. Okay? So it makes sense that healthcare costs are increasing, right? Our population's increasing. Inflation year to year. There's inflation among healthcare. Increase in the utilization of services. Problem is, we can't do much about the population. And I don't think we're going to start limiting our population like China has. As far as general inflation, there's not a lot we can do about that either. Inflation, it's gone up. Deflation occurs. It's just, I guess, part of the economy. We can do things about healthcare inflation and utilization of our services, though. So per person healthcare costs have only continued to increase. So I don't know if you can really see it, but on the bottom there, 1960 to 2016, you can see that per person each year since 1960 have only increased. And U.S. population increase versus healthcare expenditures doesn't explain the increase in expenditures that we have. So just because our population is increasing, I mean, you can see it's not really affecting much of the healthcare expenditures in recent years since 2000. It just jumped up there. General inflation is not as significant as healthcare inflation is and healthcare costs. So you can see the yellowish line there. That's national health expenditures, our GDP, and U.S. population.
Wow.
So healthcare inflation can't be that much greater than general inflation, right? Yeah, actually when we compare and look at all other goods and services in the U.S., so food and beverage, housing, apparel, transportation, medical care, recreation, education, communication, other goods and services. See medical care up there? It's rising the fastest. It's what? We spend a lot on healthcare. It's necessary because we have such a high life expectancy, right? Not really. So right now, as of a couple days ago actually, our life expectancy just decreased again. We live on average 78 years in the United States. That goes for men and women. Women typically live a year longer. The most successful in this is actually Japan. It's not really well known why. I don't even know a lot about their healthcare system, other than the type of model it follows, but they're just the most successful. So snow days in college. So the entire time I have been at Purdue, there have only been 2 snow days. My favorite, my freshman year biology exam. I was trying to get to the exam, I get an email saying, no matter what, we will have this exam. 20 minutes later, university cancels everything on campus. Absolutely no exam.
So were you excited for taking it, or did you have to take it?
Oh, we had to retake it on a weekend. It was horrible. Yeah, you don't get out of it. So how do we make spending more efficient? Well, we can either deregulate or we can regulate. Yeah, that's really the only options we have, right? So how does managed care relate to all this? Managed care is an approach to the delivery of healthcare services in a way that puts limited resources to best use in optimizing the care of patients. The goal of managed care is to have high outcomes with lower cost. From a managed care viewpoint, we can look at where the money in healthcare is going and where it's being wasted. So how much is wasted annually, just in healthcare? 750 billion. That's a lot of wasted money right there. How much do you think we spend on healthcare?
Can you talk about, when you say waste, like why or where, how are?
Unnecessary services,
Okay.
inefficiently delivered care, excessive administrative cost.
Like, what would be examples of those?
Yeah.
For unnecessary services?
I mean, for all of them if you want, but yeah.
Okay, so like unnecessary services, say you're going to the doctor to get your foot looked at, but they want to do an MRI of your head, which makes no sense, right? Completely unnecessary for what you went in there for. Inefficiently delivered care. So let's say a drug was supposed to be given to you by mouth, but the nurse dropped it on the floor and forgot to for whatever reason. It never got to you. Excessive administrative cost. Just the cost of the administrative process, the billing, things related to management in hospitals. High prices, we'll talk about high prices more hopefully. Prevention, so this just refers to like things such as vaccinations, especially we talk now a lot about measles. The fact if you were given the measles vaccine, you're treated, you're good, you don't have to worry about it. But now we have a belief where parents choose to not vaccinate, and it's no longer as preventable because of that. And then fraud, Medicare and Medicaid fraud are huge. And there's a lot of examples in news stories that you can see that. Can I answer your question?
Yes.
Yeah,
thank you.
good.
So how much do you think we spend? Your guesses? It's okay. 3.3 trillion. That's just how much we spend on healthcare in the United States. Who is that money going towards? So I want you to notice the funnel shape and spending. Look at those about 65 to 69, they really start to utilize our resources. So essentially all of that money in public funding is funding citizens of the US greater than 65. That's where our biggest cost is.
And at that point, we would want to expect like a lower life rate. I mean, if you were a government standpoint, I mean.
So you're saying, do we want to kill off people?
I'm not saying that, I'm just saying. Our money would be more efficient if like our like.
I don't think that will ever. I don't think we'll ever start to purge in the United States.
More like the giver.
It's true. A lot of it, we're looking at increasing the age in which people are eligible because of our high life expectancy. When they first started Medicare and Medicaid, they weren't expecting people to live much past 65. I think when they initiated it, the life expectancy then was maybe 66 or 67 years old. So people are just living so much longer now. And that's a large contributor to why we spend so much. Do women in general outlive their male counterparts? Yeah. Women have 1 extra year normally.
Why is this study better?
Because they live longer. So males on average die at a younger age compared to women.
Okay.
So we spend more on women because they are utilizing the system more.
So what accounts for the big difference in shape between like total spending and spending per person?
So the issue with per person, essentially it's because of the amount we utilize because of these elderly individuals. That attributes to a lot of our excessive healthcare spending. Why healthcare expenditure is so large. So when we look at per person, it's basically the same thing we're looking at. Does that kind of make sense? Even though I divide per person, it doesn't make a huge difference because we're spending so much. Our population is not increasing at the same rate of our healthcare expenditures. So we will continuously see it rise. Okay. Where does healthcare spending go? In terms of spending, physicians and hospital care are actually bigger issues than pharmacy. I know a lot of times in the news you see pharmacy drug prices. Don't get me wrong, it's a huge problem for pharmacy. But your big culprits, hospital care and physician and clinical services. A lot of times people don't go after doctors is they're not seeing that full cost associated with their bill. So Medicare and Medicaid, depending on what you're in the hospital for, will essentially cover everything. So when you see that bill, you see a zero. But when you go to that pharmacy, you have a copay. So you will always see how much that drug costs to you. Now, most patients don't look past that zero on their Medicaid and Medicaid bill, but they get mad that they're paying $13.44 on that prescription drug. It makes sense. But it's the cost that they essentially feel. So we'll talk about some drugs. Yeah. So we have brand drugs. Medications sold by the original creators. Generic. Version of a brand name drug sold by a different creator. Typically, not always the case. Biologic. Proteins, complexes, they're very hard to make a generic. You can essentially think of them as brand drugs. But generics, so there were 12 approved, right now there's 14. 2 of them, they have already said, we will not produce in the United States, we just want to get it approved. I don't know why. That's just the way it works. Specialty drugs are very expensive drugs that require special handling or training. These are uncommon. Go ahead.
The biologic seems like that's a word I've heard a lot in the last couple of years in the
Yeah.
pharmaceutical medical. Can you give us just a couple like appropriate uses or what areas are those being introduced in?
Diabetes and insulin.
Okay.
Insulin is a biologic drug. That's probably the most well-known. There are other ones, which I have the top 10 drugs sold in the U.S. So we'll get to that. But insulin's probably the biggest one. And the issue now is we don't really have a generic for insulin. So 10% of brand name drugs make up only a tenth of all prescriptions being filled in the U.S. Yet they account for 77% of prescription spending for Medicare and Medicaid. So brand name drugs are a huge problem. How much do we spend on these drugs compared to other countries? Most. So this is a graph that I found in literature of the retail price index. So you see our country is being used as the base here. Think of that as like 100%. So for every 100% we are spending, UK is spending 81% of that. Does that kind of make sense? there are countries, and these different rows are just different drugs that they were using as comparisons. Now, there are countries that pay more than us. Switzerland, France on certain drugs. But in general, we spend more. How long does it take to get a drug approved to enter the market? 10 to 15 years. Normally you have to have a discovery phase. You go through 3 clinical trials. And now in the US, the FDA is requiring a phase 4 trial, which is aftermarket, looking at side effects, adverse events, that just occurs maybe 5 to 10 years once the drug is released. Sometimes there's side effects that they don't catch during clinical trials. And the hope is that by doing these phase 4 trials, we can find those. You know what I mean? When you have to teach yourself a subject because your teacher is useless. I hope that you never have a useless teacher in college. Normally it's not teachers. It's normally not the teachers that are the issue. It's the teaching assistants. What are the most common health conditions in the US? High blood pressure, cholesterol, diabetes, back pain, anxiety, obesity, allergies, influenza, pneumonia, acid reflux, and low levels of thyroid hormones. What about the most common drugs? What are they used for? We see Humira, RA, Abilify, mood stabilizer, Sovaldi, hepatitis C, Crestor, cholesterol, Enbrel, RA again, Hep C. So only 3 of these have a direct FDA approval to treat the most common conditions Americans have. 7 of these are actually biologics too. So why are drugs so expensive? It's a high cost and complicated to get a drug from manufacturer to a pharmacy. Intellectual property laws. There are laws that just don't make sense. Combining drugs or developing unique delivery systems for them. Research and development of drugs. Manufacturers setting outrageous prices. And manufacturers actively preventing generics from reaching the market. So this is kind of complicated.
I'm sorry, can you go back to that one?
Yeah.
You'd mentioned previously like that, such a large body of the drugs that are used, as far as cost-wise, are only representing a few of the individual drugs. These are some of those then that are?
Yes.
A lot of these are the expensive ones?
These 10 are some of the most expensive we have in the United States, and I put up there how much. So Humira, $8.2 billion is spent on Humira each year. $7.9 billion on Abilify.
So
$6.9 on Sovaldi.
Now you can't say every single one, but many of the most common used ones are also the most expensive ones.
No, that's the problem. They're not the most commonly used.
Oh,
So we look at the most common that people suffer from in the United States, health conditions. But of these, only 3
oh, I see.
have a direct approval. So a lot of what we're spending on are specific patient populations.
I see, all right.
This